PARP inhibitors have known efficacy in prostate cancer. There are prospective phase 3 trials that were well done that show that PARP inhibitors relative to either androgen receptor pathway inhibitors or chemotherapy improve survival in patients with notably BRCA mutations and some other HHR mutations as well. These recent studies were designed to evaluate the combination of androgen receptor pathway inhibitors and PARP inhibitors. So PROpel evaluated olaparib and abiraterone. TALAPRO-2 evaluated enzalutamide and talazoparib, and Magnitude evaluated abiraterone and niraparib. And some of these trials accrued all comers, but I think that the FDA thus far has approved these combinations primarily for people either who have BRCA mutations alone in the case of olaparib and niraparib, or other HHR mutations in addition to BRCA2, BRCA1 mutations for the enzalutamide talazoparib combinations. So the approvals were based on three large phase 3 trials that demonstrated a progression-free survival advantage of the combination of the PARP inhibitor and the androgen receptor pathway inhibitor relative to the androgen receptor pathway inhibitor alone. So what this data told us was that the combination of treatments delayed progression relative to one treatment alone. And so that was the progression-free survival advantage that had been presented and published, and that was the basis for the approvals. I think that there are some concerns that myself and others have raised about the use of these agents. It's also worth noting that this is in first-line metastatic castration-resistant prostate cancer patients. And previously, these androgen receptor pathway inhibitors were used alone. And based on published data that came out in around 2020, PARP inhibitors were used thereafter. And so they were used in sequence. And so what this data demonstrated is that the combination was better than single agent androgen receptor pathway inhibitor alone. And so there are trends to survival benefits depending on which trial we're talking about. But I think the important thing to really understand in this, and this is where my primary concern comes from, is that there was a lack of functional crossover in these trials. So if we look at these trials individually, we see that subsequent PARP inhibitor therapy was actually the exception and not the rule. So in standard practice in 2023, if I have a patient who progresses on, say, abiraterone or enzalutamide, I would provide them a PARP inhibitor based on a HRR mutation. But in these trials, that rarely happened. And just to give percentages that we know of behind, kind of the statement, for the Magnitude trial, it's roughly 28 to 33% of patients, depending on how you slice the numbers, who are on the control arm, who were known to have a mutation that would benefit from a PARP inhibitor. Only somewhere around 30% of those patients went on to get a subsequent PARP inhibitor. For the TALAPRO-2 trial, it was closer to 17%. That's with talazoparib and enzalutamide. And for the abiraterone olaparib trial, it was only about 2%. So what these trials really identified wasn't an optimal sequence of therapies. It really evaluated the benefit of treating patients with PARP inhibitor in combination with an androgen receptor pathway inhibitor, or perhaps never, for a large, overwhelming majority of these patients. And so that is why others, including myself, have raised concern that the progression-free survival advantage is noteworthy and important, but it's kind of without context because we don't know if sequencing these therapies would have been as effective as giving them in combination. And unfortunately, because of this lack of crossover from these trials, future survival data in follow-up will not validate progression-free survival. because so many of these patients went without PARP inhibitor therapy, and we know they'll have worse outcomes. And I think we need to understand why this is even a question. Like, why would people like me even say, well, why are we doing this? And the reason is the toxicity. You know, if PARP inhibitors introduce no toxicity, then there really wouldn't be a problem with adding two therapies earlier in the disease state. But unfortunately, there were significant toxicities. They included, and these are well described with PARP inhibitors, not just in prostate cancer, but beyond. And three of the main ones that kind of stick out in my mind are, you know, kind of issues with GI symptoms. There's also some fatigue issues, I think, but the GI symptoms that can happen with PARP inhibitors, as well as the myelosuppression issues, and specifically a very high rate of transfusions that were as high as 25% and beyond in some of these trials. That patients required blood transfusions, which are impactful in terms of how patients are able to live their lives. And so, I was asked at ASCO this past year to discuss the quality of life data from TALAPRO-2 and PROpel in the context of these trials. And I'm not a quality of life expert by any stretch. There's much better qualified people out there. But I do like to think I pay attention to the quality of life of my patients in the clinic and try to incorporate that into the treatment decision-making process. So from my perspective as a clinician, the quality of life data would be very, very helpful in a circumstance where there was no perceived difference in toxicity. Now, it is worth noting that in the PROpel trial, there really wasn't a difference in quality of life. Both groups seemed to have the same perception of quality of life. In the TALAPRO-2 trial, there was perhaps a slightly better global quality of life assessment relative, and maybe associated with progression-free survival benefits. But I think we have to take a step back and say, how does a clinician interpret that? And from my perspective, the way I kind of wrestled with it a little bit, but the conclusions I came to, that as a clinician, quality of life assessments are important to me when we don't have any perceived difference in toxicity. If we think that, let's say, the toxicities are relatively equivalent, then quality of life comes into play. Or let's presume there is no toxicity, and then quality of life tells us there is a big difference, and we're missing that with our quality of life, with our toxicity assessments. In those situations, I think quality of life adds a dimension to our understanding of the clinical experience and the quality of life experience of these patients. But what actually is the case here is the opposite, where there's very obvious toxicity differences, and the quality of life doesn't seem to reflect that. So again, being somewhat naive to the whole quality of life approach, digging into the literature, I realized that as a clinician looking at this data, I'm just thinking it's patient plus drug equals quality of life. But there are so many other factors that come into patient perceptions of quality of life that it goes well beyond that. And for a patient who's told that they have metastatic prostate cancer, their quality of life might just be buoyed by the fact that, that they're doing well and they're still alive. And that, yeah, I have to get a transfusion, or yeah, I have a lot of toxicities, but I'm happy enough to be able to spend time with my family and do the things I love. And so perhaps we're not getting the same data from these quality of life metrics that we think we are. I would put it in the context of, if I had a patient in my clinic right now with a known BRCA2 mutation, and they said, what can you tell me about the known data of a PARP inhibitor with an abiraterone or enzalutamide versus abiraterone or enzalutamide alone? what can you guarantee me based on existing data? And unfortunately, from my perspective, this data tells me I can only guarantee them earlier toxicity because the data cannot guarantee that they will live longer. So it does say that they will have delayed progression, but I don't know if that's necessarily the case if we sequence these therapies. So there's a nuanced conversation around progression. But in terms of toxicity versus survival, the only thing I can guarantee them, unfortunately, is increased toxicity. And I can't guarantee increased survival versus a sequencing regimen where we can defer the toxicity for maybe a year, maybe many months beyond that.